Hello everyone. It's a pleasure to be with you at the 2020 UMA virtual meeting. My name is Carolina Weller and I'd like to extend a warm welcome to every single one of you. Thank you for participating in yet another online forum. I'm coming to you from Melbourne in Australia, and like many of you, I've been working from home, or perhaps we could better describe it as coping from home. This 2020 UMA meeting will be remembered as one like no other when COVID intervened. Although we cannot travel and connect as usual, I'm glad we can get together in this virtual space and connect right across the globe. Today I'd like to talk to you about partnering with patients with venous leg ulcers to improve healing outcomes using an evidence-based perspective. And I'll keep it nice and short and concise, although 3 points that I will bring up at this point that I hope stay with you is that partnering with patients is important. Community involvement in clinical care and research is possible, and patients can identify and prioritise research topics, especially when there's an equitable relationship. A number of studies that have presented today have been funded by the National Health and Medical Research Council. No other conflict of interest to declare. Now, I'm not going to go through venous leg ulcer etiology or epidemiology. That's been covered by my colleagues today and probably on other occasions. What I'd like to concentrate on is where we are at the moment and perhaps what some of the issues will be for us. So we know that an ageing population means that we have a growing economic burden, and it's going to shift the healthcare needs. With ageing comes an increasing number of people with venous leg ulcers who will suffer. And these ulcers, we know, not only are expensive, but impact on the individual's quality of life. Now, we can keep going as we have been up to 2020 this year with the treatment plans that we have in place. Or we can try and think about modifying our way of engaging with the patient and our treatment management to include patients in their care. Each of us here knows that best practice for venous leg ulcers is compression. Although what we still don't know is what is the ideal sub-bandage position, avoid healing and not inflict pain, because quite often, because of that pain, we actually end up with non-adherence to compression, the best practice treatment. And we know no compression means that healing will not be imminent. Now, here's a piece of work that was published last year, where we looked at what are some of the barriers to the use of venous leg ulcer clinical practice guidelines in Australian primary health care. Now, we looked specifically in primary health care because that's where most of the patients with venous leg ulcers are looked after. They're usually the first point of call, and then community nursing sort of takes over and hopefully at some point, if things aren't going the way they should be going and the patient hasn't healed within that 3-month period, then there's going to be a referral. But what we found was that patients and clinicians reported differing perspectives related to venous leg ulcer management. Patients reported the need for earlier referral to a specialist wound care clinic from primary care, emphasising the need for vascular assessment and compression therapy, which they say didn't happen very, very early enough. Clinicians also discuss clinical judgments about when to refer rather than follow guideline recommendations. Clinicians tended to manage venous leg ulcers using topical dressing treatments without compression therapy. That was quite a common thing that they spoke about in this particular piece of work. Patients reported inadequate pain management for wound pain. Meanwhile, the clinicians reported that they generally didn't discuss wound management as part of the overall venous leg ulcer management. The clinicians reported patients lacked an understanding about the role of compression in management of and subsequent healing outcomes. Patients stated they wanted more information about how to care for venous leg ulcers and how to prevent recurrence, and they needed more information than was already being provided by clinicians. Whereas clinicians reported less information is given to ensure that patients were not overwhelmed with health information. So in essence, we have clinical practice guidelines, but they're not used, and our clinicians tend to defer to other healthcare professionals to guide venous leg ulcer treatment. Now, a recent analysis of a fairly large data set, looking at the sort of, if you like, the national Australian patient encounter data set in primary care, identified that of more than 970,000 encounters between the GP and the patient, only 2% were treated with compression and less than 5% were referred to a specialist within that timely manner of 3 months if they weren't healing. Now, when we look at this at the grassroots level rather than a huge data set, we identified further discrepancies. These discrepancies were what patients want and what clinicians actually do in relation to venous leg ulcer assessment, diagnosis, treatment, referral, and health education, as is outlined in the clinical practice guidelines. So there are some issues there that sort of started us thinking that we know that there are venous leg ulcer clinical practice guidelines out there, and a lot of folk actually in primary care know that they're out there. They may or may not agree that compression is needed for their patients. Quite often they'll tell me that, well, my patient is different and they won't wear compression because. So there'll be some interesting sort of conversations around that. But what we thought was we needed to develop a community involvement and partnership platform with patients who experience that venous leg ulceration suffering. And so we developed the Wounds Advisory Group in 2019. And we did that for a number of reasons. One was to facilitate the improvement of using best practice evidence in healthcare. Secondly, to facilitate patient involvement in research priorities, because we thought the patient voice was something that was being missed. And thirdly, to facilitate a collaborative approach across the globe to facilitate this community involvement with international leaders in this space. We used this particular patient involvement matrix, which shows you the 5 main sort of patient involvement steps, and you can see a low level of engagement is simply to inform somebody or to consult with them. But if we involve them and if we collaborate with them and we empower the patients, that then gives them a high level of public engagement and more likely to be heard in that sort of space where quite often patients aren't allowed to play. This is based on Cochrane Australia. There's a facilitator's manual and resource document. We looked at this after looking at a number of papers to see what is actually being done in this space across the globe. And there are some papers out there that talk about some of the barriers, and there are also some papers out there that have hinted towards some enablers in this patient involvement space, which we used to guide the next phase. I'll go back once. And here what we were, you can see in the back of the PowerPoint in the photo, is we had a priority setting session where these people were asked, what is the most important issue for you? And here you can see what they identified as top priorities for venous leg ulcer clinical care and perhaps for research priorities that they felt needed to be investigated. So looking at making sure that the products were more affordable, that health professional gave the best evidence advice in a timely way. They made an early, correct diagnosis, that the healthcare professionals actually talked to each other so that they didn't get so many differing opinions about what advice they should be given. They acknowledged that they had to be patient through that healing process because they've been through it a number of times. As you know, people with venous leg ulcers don't just have one. And their need for that accuracy of information, the right knowledge by the healthcare provider, as well as easy access, were actually quite high on their priority listing. Now, here's the whiteboard of the humble beginnings that started this process, and you'll see that the cost of compression and dressings are high on the list. Now, when we first started discussing it, you can see number one there is best advice from health professionals. That was their priority. And it was only once we sort of went through this again that they realised that, hang on a minute, the cost of these things are quite prohibitive. In Australia, we don't have a subsidy for compression or for dressing products. So this was actually quite a big issue for them. And the other interesting part about this was the discussion about the impact of the venous leg ulcer on their life. And you can see that they've actually identified a number of things that impacted them, also impacted their family, and also impacted their carers. So we come now to those three main points I wanted you to take away from this session. And that is that if we are to improve the way that the patient outcomes and healing outcomes for people with venous leg ulcers, then we need greater community involvement, both in clinical care and in research, so that patients feel that their voice is heard when they share their lived experience and their expertise, because they're living through it. And it needs to be meaningful and relevant to them in order for them to engage. They need to understand what needs to be done and why they're doing it. So patients identifying and prioritising research topics and questions is also a very, very important fundamental need. And including patients in this process means that we have set up an equitable partnership where there is shared decision-making and hopefully improved clinical patient outcomes. Our next step is to undertake a scoping review. That's in progress. Protocol is under review at the moment, has been submitted. We're doing this with our colleagues in Switzerland and in Ireland. And what we're going to do is investigate the relationship between patient health education and health literacy, and how that impacts on patient venous leg ulcer outcomes. And the two main sort of elements we're looking at is the adherence to compression and healing of the venous leg ulcer. And we hope to bring you those findings at the next UMA meeting and hopefully face-to-face. I would like to acknowledge a number of people. The advisory group, my research team at Monash University, without whom I could not have done the work that I'm presenting to you today, and I thank them most sincerely. And also for the funding from the National Health and Medical Research Council, and I put up a number of references here for you just in case anybody is interested in taking on something like this in their own country. Feel free to contact me if you're working in this space. I'm more than happy to share what we have learnt. And finally, I would like to dedicate this presentation to all the nurses. It's the International Year of the Nurse. It's been probably one of the toughest years that we've had for nurses and healthcare professionals across the globe with COVID.